inverted supracondylar fracture leading to a cubitus varus deformity is a common exam case. So you should know how to treat the primary fracture as well as the sequelae of a untreated or a neglected fracture. Now, traditionally, this fracture is classified by the Gartland's classification, where we have a type 1, a type 2, and a type 3. A type 1 is an undisplaced fracture where you can actually see the movement of the anterior fat pad and a visible posterior fat pad. That is something which has been described very well in literature. So I will not go into the details of that. So the type 1 is you tend to immobilize. And type 2 is you tend to reduce and fix. This is an angulated fracture. The type 3 fracture is a displaced fracture in extension or flexion, which you need to fix all the time. And a type 4 is an extremely unstable fracture, which you have to reduce and fix. These are traditionally the most difficult fractures to fix. As per the traditional classification, direction of displacement defines the way in which it has to be reduced. So there is an extension type supracondylar where the distal fragment is in extension angulated or displaced posteriorly in extension as compared to the proximal fragment. And there is a flexion type of supracondylar fracture where the distal fragment is comparatively in flexion or displaced anteriorly or angulated anteriorly. The mechanism of injury for both these fractures are different. The flexion type actually happens when a child lands on a flexed elbow, and an extension type happens when a child lands on a extended forearm. At the same time, what happens is that the tip of the olecranon actually pushes the distal fragment, leading to a break in the part which is the least strong of the distal humerus. The extension type of fracture you have to reduce in flexion, and the flexion type of fracture you need to reduce in extension. So this is how you reduce a extension type fracture in flexion, and this is how you reduce a flexion type fracture in extension. So all this is what is described in traditional literature. But if you actually look at it, there are certain issues with this traditional classification. It definitely tells you about the magnitude of the injury. There is no question about that. It also tells you the direction of the injury as to flexion type, extension type, type 1, type 2, type 3, where type 1 is the least severe, type 4 is the most severe. However, it does not take into consideration the sagittal and the coronal obliquities because these fractures have different configurations. And hence, you cannot have a single treatment approach to different kinds of configurations of fracture. It also does not tell you about the management algorithms because now that we have understood that there are different structural components to these fractures, different coronal plane fracture lines, because of which the management algorithms are different. And also based upon this, the prognostic value of injuries change. And hence, the traditional Gartland's classification is not really enough for us to understand and treat this fracture as well as its sequelae. Now, essentially, to try and understand a supracondylar fracture, one needs to understand the fracture patterns. And the fracture patterns can either be in the coronal direction or they can coronal plane or they can be in the sagittal plane. So the coronal plane fracture patterns are a low transverse, a lateral oblique, a medial oblique, and a high transverse. And similarly, there are sagittal plane fractures as well, fracture lines, which I will come to later. Now, coming to the first type, the type 1 coronal fracture pattern in supracondylar fractures. This is a typical low transverse fracture with less than 10 degrees of coronal obliquity, with the fracture plane entering and exiting near the epicondyles. This is the commonest injury. Now, this is how this fracture pattern opens up with a kind of a medial angulation and a medial displacement. And based upon extension type or flexion type, there may be a posterior or an anterior angulation. And this is the classical fracture pattern, which can be fixed with cross KYs, or even 2 lateral KYs, or even 3 lateral KYs. So it does not really matter how you fix this, because as long as you get a good hold on both the fragments, which is possible using the cross KY technique, using the 2 lateral wire technique, and using the 3 lateral wire technique, you can get a reasonably stable fixation. The second type is a lateral oblique fracture pattern in the coronal plane, wherein there is more than 10 degrees of coronal obliquity with proximal fracture line extending laterally. Now, this is a little different from the transverse fracture. So this is what the fracture looks like. This is how it opens up, and it can displace medially, it can angulate medially, it can angulate anteriorly or posteriorly based upon the mechanism of injury. Now, here you can fix these fractures with 2 lateral wires, with 3 lateral wires, but the problem is when you put the medial wire. The reason for that is because the distal portion of the medial side is comparatively smaller as compared to the lateral pillar of this particular fracture. Putting 2 medial wires or putting 1 medial and 1 lateral wire will give you a very unstable construct. So even if you want to put a medial wire in this particular fracture, you have to put something which is less oblique and more vertical, means a little more in angulation. You have to increase the angulation so that you kind of exit on the lateral distal cortex of the humerus in a way that you get a good fixation. But the best fixation for this kind of a fracture is 2 or 3 lateral wires. The third coronal pattern in supracondylar fracture of the type 3 is the medial oblique fracture with more than 10 degrees of coronal obliquity with the proximal fracture plane exiting medially. Now let's look at this particular fracture. So this is the fracture line. This is how it opens up, and these are the fractures which can go actually into cubitus valgus or cubitus rectus. Now here you actually would require medial pins in addition to a lateral pin, because purely putting lateral pins here will not give you a good amount of stability. And hence a combination of 2 lateral, 1 medial or 2 medial pins. And again, I would like to warn you that whenever you're putting a medial pin, you need to do a little bit of opening. You need to bluntly dissect out and be certain that your K-wire is not engaging on the ulnar nerve. And then either using a drill sleeve or a tap sleeve, you should insert these wires from the medial epicondyle or a part of the medial condyle. But be very, very careful that your wires do not engage the ulnar nerve or do not irritate the ulnar nerve while putting the medial wires in any supracondylar humerus fracture. The type 4 coronal variety is a high supracondylar fracture, wherein the fracture plane entering and exiting is way above the olecranon fossa, but within the distal humeral metaphysis. Now, these are the tricky ones because they are quite unstable, and they are seen slightly in older children. So these are difficult to reduce and difficult to hold, and you need to plan how to fix them. So this is exactly what the fracture pattern looks like. This is how it can displace. These are extremely unstable fractures. Many a times they are type 4s. Many times, as I told you, seen in older children. Unstable fractures, you actually need to have good pillar fixations. So even if you're planning to put 1 or 2 wires, you need to see to it that these wires cross either at the fracture site or over the fracture site, and you get a good fixation in the medial and the lateral pillars. Now, similar to what I told you regarding the coronal fracture pattern, there is also a sagittal fracture pattern. So the sagittal fracture pattern can either be a transverse fracture or a posterior oblique fracture where the line kind of exits from posterior to anterior. So this is the transverse fracture pattern in the sagittal plane or the type 1. Low sagittal fractures, fracture plane less than 20 degrees of angulation. Type 2 is the high sagittal fracture where the fracture plane is more than 20 degrees of angulation. Why is this important? It is important because, as you know, the way to treat a fracture is to fix it at an angle which is at almost 90 degrees or perpendicular to the fracture line. And hence one needs to remember that once one is fixing a fracture like the transverse fracture, you can actually be more vertical in your approach or your entry after reduction. But when you're trying to fix an oblique fracture, which opens up this way, then rather than trying to go vertically, you need to put your wires obliquely, which is perpendicular to the fracture line. And this is how you fix these kind of fractures. Now let's look at the fixation technique. Now this is a displaced supracondylar fracture, maybe a type 2, which is a low transverse and a sagittal oblique. If you see, that is the distal fragment here, and it is an oblique fracture. It's a sagittal oblique fracture. So as I told you, that when you fix this fracture, you need to have a proper planning as regards how you're going to put your K-wires. So the first step is going to be the reduction. And what is the reduction maneuver? The reduction maneuver is traction, counter traction. You tend to then correct the rotations and see to it that the proximal and the distal fragments, that is the arm and the forearm, are in the same rotation. You try and correct the varus valgus strain so that you have a cubitus rectus or a little bit of a cubitus valgus depending upon the opposite side. And once you do that, you tend to milk the distal fragment in place by putting your thumb over the olecranon fossa and trying to flex it for it to reduce against the proximal fragment. At the same time, you flex and pronate the forearm. So this is how it is done. The first step is traction. Once you do that, you adjust your varus valgus and see to it that you are in a perfect plane. The rotation is important. And once you do that, traction, counter traction, and milking the fragment. Just look at my right thumb. I'm milking the fragment and I'm going flexion pronation, so which basically flexes and pronates the distal fragment. So this is a extension type supracondylar where I have done flexion, and now I'm going to check my reduction. So this is the anterior posterior view, and this is the lateral view. I am reasonably happy with my reduction. And now that is done, I'm going to start putting wires. So my first wire here is going to be a trans olecranon fossa wire. Now this trans olecranon fossa wire starts from the lateral condyle, enters the olecranon fossa in almost the middle of the distal humerus, exits the olecranon fossa obliquely, and then goes to the medial pillar. So this is where my wire is. It is going through the olecranon fossa. I get a forecortex hold, and you can actually feel this. So if you're feeling it, then you are definitely there. And if you see my posterior direction or my posterior trajectory, I am going from posterior to anterior so that I can get a good hold on the oblique fracture or the oblique plane of the deformity. Now I'm going to be putting my second wire, and whatever I'm doing, I'm checking it under the Siam. So once I push that, I confirm that I'm going right from lateral condyle into the medial pillar, and you can actually feel the resistances. So this is my second wire going from the lateral condyle, diverging and going towards the medial side and getting a hold on the medial cortex. And that is how the posterior to anterior wire goes. So you can be slightly lesser oblique, but if you see, my wires are perfectly perpendicular to the fracture plane. And this is how you fix a sagittal oblique and a coronal transverse fracture. Once I do that, the next step is bending the wires. And I may not be using the correct instruments here, but what I'm trying to tell you is you need to bend the wires correctly. You get a The wires don't hurt the patient. So once you bend the wires, you take your final shoot. So that is the final anterior-posterior view. 2 wires are enough. Younger child, transverse fracture in the coronal plane. So 2 wires are enough in this case. That is my sagittal, where I am quite happy with my reduction as well as with my fixation. So this is another case, again, of very displaced fracture. But here, if you see the fracture pattern, this is a transverse sagittal and a transverse coronal fracture. And hence, the direction of the wires are different in this case. So the direction of the wires in this case are going to be a little more vertical as compared to the previous fracture. Now, there are certain fractures which are difficult to get a reduction for multiple reasons. One common reason for that is an unstable fracture where you really need a little bit of experience in dealing with these fractures. And a few fractures are such which have soft tissue interposition, or many a times have the proximal fragment, many a times buttonholes through the brachialis muscle, and that can lead to irreducible fractures. So these are irreducible fractures, and whenever you have an irreducible fracture, you need to rule out a neurovascular injury. It's extremely common to have neurovascular injury in irreducible fractures because these are high velocity injuries, these are severe injuries, these are almost type 4 injuries. And many a times the proximal fragment is buttonholed through the brachialis muscle, which is causing some sort of a soft tissue interposition. And here, what is important to understand is you need to remove the soft tissue interposition. So this was a paper which we published in the Acta Orthopedica Scandinavia in 2005 about the minimally invasive surgical technique for irreducible supracondylar fractures of the humerus. And in this technique, what we do is we do a minimal medial anterior open. We tend to dissect out the soft tissues with the help of a suction tip. We then push the distal fragment in reduction to the proximal fragment, and then we manipulate the distal fragment with the help of K-wires to put the first lateral wire to get a reduction. The second way to do it is you can joystick the proximal fragment, provided it has not buttonhole. If it has buttonhole, then you will have to do an open release many a times. But many a times you can use a joystick method in which you can put the joystick into the proximal fragment. You can slowly get into position, and once you get into position, you can do a fixation maneuver. Many times you get a flexion type of supracondylar humerus fracture. These are extremely unstable injuries, and you need to remember that these are quite difficult to fix in extension. So when you're not getting a reduction in extension, or if there is a displacement in extension, try and figure out if this is a flexion kind of a supracondylar fracture. And if it's a flexion kind of a supracondylar fracture, it has to be reduced in extension. Like this particular fracture here, a flexion type, which had to be reduced in extension, and that is how it was fixed. So to summarize my talk for today, supracondylar humerus fractures are quite common injuries. The primary fracture and the sequelae of the fracture which is not treated is a common condition which presents to orthopedic surgeons all across the world. One needs to understand the plane of the injury and the direction of the displacement so that one can plan a fixation technique. One needs to take care of the barriers in the reduction, as I mentioned. And if there is any barrier, that barrier has to be crossed. One needs to get an anatomical reduction to prevent or reduce the level of deformity which can happen once the fracture heals. And one needs to have a stable internal fixation. The internal fixation will depend on the configuration of the fracture. And if you have a configuration which is oblique in the anteroposterior and the lateral plane, then you have to change the way your guide wires, your K-wires are inserted so that you get an optimal fixation. With this, I thank you very much for your kind attention. And if there are any questions, I would like to take them now. Thank you.